Hi, everyone. Thank you for joining our pediatric subcommittee call today. Michelle Jackson and I are going to give you guys a few brief updates to start, and then we will be turning the reins over to Brian Reyes, who's graciously agreed to present today. So just to start out with a few updates, I just wanted to update the membership on the referral guide. So we are still making progress with that. Allie Slutman had taken the results of our last call with the automatic referrals and sent a revised version to me. So we will be getting that to NSGC for some further formatting. We had also discussed an appendix. Right now, we are tabling that just because we are aware some other publications will be coming out with that information. And so we'll keep you updated as that evolves. And then I also wanted to let you guys know that we are still working on a heme malignancy referral guide. Rose McGee and the other St. Jude counselors will be doing that and are hoping kind of for a March deadline there. I also wanted to give you a heads up that we have been discussing in the background a little bit about a pediatric cancer starter packet for people that are new to practice that might need some resources like slide sets or letters of medical necessity, patient letter templates. And we were thinking of doing a short survey monkey where we send you guys just a 5-question thing about what your needs are as related to any type of a starter packet. So I'm not exactly sure when I'll get that out to you, but that should be coming. And then I believe that the other updates are going to be provided by other members here in just a second. So I'm going to turn it over to Michelle and then Kristen Zajo to update us on our survey, and then finally Brian will get started. So Michelle, you should be unmuted.
Can you hear me?
Yep.
Okay, wonderful. Thanks, Liz. Good morning, everyone. So just a couple quick updates that I have as well. So for the 2017 year, we would love to have, webinars on a regular basis and have kind of been brainstorming a little bit to, see what the format of those should be, or, if we should change that up, or, kind of what we need to be thinking about in terms of webinars. And so if there is someone out there who is interested in kind of being like our webinar coordinator and helping us think of topics, and kind of taking the lead on that, that would be wonderful. Please let me know. You can email me directly if you'd like, and I can talk to you more about it, and give you any information and definitely help out with that. But if someone is interested in kind of thinking of topics, or we talked about potentially doing journal clubs or something along those lines, to kind of change up the format every now and then. So if that's something you're interested in, please let me know, and I can talk to you more about it. The other update that I have, Zanelle Pond and a couple others have been working on a somatic lab comparison sheet. And it sounds like they're making pretty good progress on that, but are potentially interested in more volunteers to help with that process, so we can get that finalized and out to everyone. I think Danelle's goal is to possibly have this out by the end of February. So if there's anyone interested in helping with looking at the labs that are doing somatic testing and kind of getting some details about that, or helping in whatever way Danelle needs, please contact her directly, or if you can't find her email address, you can always email Liz or myself, and we can get you in touch with her to help with that as well. Okay, and then the last update that I have is about the NSGC AEC submission that we have done for the conference this coming fall in Columbus. So we ended up submitting a couple different things. This all came about because there were 3 separate groups of us. There was a group from the Pediatric Cancer Subcommittee that had written a proposal. Myself and a couple other genetic counselors had written a proposal on hereditary brain tumors, and Sarah Bannon, a genetic counselor at MD Anderson, had written a proposal on hematologic malignancies. And so the Cancer SIG organizers connected all of us to see if we would maybe want to do a joint submission for like a pre-conference symposium or a larger presentation at NSGC. So we got together, pulled it together very quickly, and submitted a proposal for a pre-conference symposium. Basically, the gist of it is that these are newer areas. So pediatric cancer, hereditary brain tumors, and hematologic malignancies are all newer areas for genetic counselors. There aren't a lot of guidelines or kind of standards of practice, if you will, in these areas, and so it can be much more challenging for genetic counselors to figure out how to evaluate these patients and their families and what testing to order. So we kind of collected all of those topics to try to present that in a way that you know, any genetic counselor, whether they be a cancer counselor or a prenatal counselor or a PEDS counselor, you know, coming across these in potential personal and family histories could tackle that and feel more comfortable evaluating and offering genetic testing if needed for those tumor types. So we will definitely keep you updated on that once we hear back from NSGC to see if that was accepted. We're really, really excited about it. And then also just so you're aware, the 3 separate groups that had originally submitted the proposals also still submitted their individual proposals as well. So hopefully, one way or the other, we'll have a good representation of these topics at the AEC this fall. So we'll keep you updated. And Liz, I think that is all of my updates.
Okay, great. So I'm going to unmute Kristen Zajo. She's going to give us a brief update on the survey that went to the subcommittee members and also the Cancer SIG.
Yep, thanks, Liz. So as Liz said, just a really brief update on the subcommittee survey. We did get about 40 responses so far to the survey. About 60% or so of those were PEDS Cancer SIG members, so thank you to everybody who did respond and take the time to fill that out. I've been just kind of combing through some of the data, and I'm just starting to look at a lot of the free response data, but if there's anyone on the call who would be interested in helping to sort of go through some of that data and think about ways that we could present this that would be most meaningful, either in terms of presenting to the SIG members or possibly considering for some sort of publication or other uses for the information, that would be great. So you could either contact me directly by email or, again, if you can't find my email, if you contact Liz or Michelle, they can put you in touch with me. So thank you.
Very good. Thank you guys for the updates. So now we are going to turn over the reins to Brian and let him introduce himself. And I do have you guys muted, and that's just to reduce the background noise during the presentation. But you can either raise your hand or at the end we'll have time for some question and answers, or after different case presentations we'll do that. So let me work on go ahead and doing Brian. Okay.
All right, can you see my screen?
I can, yep.
Okay, awesome. Well, thank you for having me. I'm one of the genetic counselors at UT Southwestern and Dallas Children's. And today I was going to talk a little bit on tumor profiling and some of the work that I do, which is sitting on our tumor profiling molecular tumor boards here at Children's and UT. So this is a topic that I took over from Megan Frone last year. And have really been involved in kind of reviewing cases of tumor profiling when they come in and helping our doctors and staff know when they should follow up on these cases. When are we concerned for germline predisposition and what they need to do with these types of results. It's been really exciting, and we've been doing a lot of this type of testing. So to get into this, what I'm going to do today is I'm going to briefly break down the types of tumor profiling that are being done, what I do versus what other centers do. I'm going to talk about some of the big topics in the field, so things like variant allele frequency, and then I have some case examples that we're going to go through of cases that I've seen here with patients, and we can talk about some of the unique challenges in tumor profiling. So overall, I really kind of consider there to be two different types of tumor profiling being done today. We do tumor normal paired testing and then tumor only testing. And this is when tumor normal is when we use both a sample of the biopsy of the tumor specimen itself, but also send in a constitutional sample, and then tumor only is when we're only sending in the biopsy of the tumor itself. And this is an important distinction because centers that are sending in a constitutional sample, by definition, are getting germline results, and they can get them separated out. So sometimes they're sending in the constitutional sample just to filter out variants that they don't want to come out in the actual report, but a lot of times they're really using that to be able to distinguish what is truly somatically gained versus what has been previously there in the germline. My center sends all of our testing out, so we don't do any of the tumor profiling here at UT. We send it all mostly to companies like Foundation, Caris, some of the bigger names, and we always do the tumor-only type of testing. The benefits of doing either of these, it's very mixed, and in the field, there's a lot of different things being done. One is that here, our genetic counselors are not involved in the consenting process, so we're not getting germline samples for these patients. They're just sending tumor, and therefore there's a very limited informed consent process. And the doctors are often not getting even written consents. It's often just a verbal consent process, just like they might do for regular pathology, very, very limited, versus places like MD Anderson, which are more commonly doing somatic and germline testing in-house. They are often consenting people that their center, it's through a research program, but maybe it's a written consent before the testing is being done. And this is being done very differently at centers across the United States, sometimes by genetic counselors, sometimes by oncologists. One of the biggest differences in this is going to be both the cost and the turnaround time, so how long it's taking to analyze the sample, but also the cost. We know that reimbursement for tumor-only testing right now is very poor, so a lot of the major hospitals that are sending this type of testing are eating a lot of the costs, and that changes the availability of this testing for many people. I see the benefits, particularly to sending only a tumor sample, as being that it's kind of, we're getting a result that's independent of the family history. So when I'm reviewing a sample that comes in from one of our doctors, say a Foundation result, really I'm reviewing this independently of the family history. We're getting just a look at the results of the tumor sample, and we're also able to look at specific mutations. So here we have an advanced look at what in the tumor is mutated, and that gives us a lot of heads up. The limitations of this is that a lot of the mutations that we find on these reports and that we see are not going to be germline. And so we get a whole list of mutations. It makes people concerned that there might be something in the germline, but the majority of them are not going to be germline, and it becomes confusing. How do you know which ones you should be concerned about? There's a lot of talk in the field about allele frequency, so the percentage that a particular mutation is in a sample, how useful is that in determining whether or not that particular mutation is likely to be germline. And it is necessary to confirm all mutations, particularly those that were just seen on a tumor-only report, to determine whether or not they're actually in the germline, i.e. we can never use a tumor profiling result when they didn't send a constitutional sample to say for certain that a patient has a germline mutation. I almost never refer to the mutations that we see on these reports as even being potentially germline, because I always say we need to confirm before this is done. And then another limitation, I guess I consider this to be a limitation, is that this testing is very confusing to families. I have to explain all the time, okay, that test that you had on your breast cancer, it was a genetic test, but that doesn't mean that it was looking for things around the germline, things that you were born with. So this is my approach to reviewing tumor profiling samples when we look at them in Tumor Board and when I'm looking at them for doctors. The first thing I'm always looking at is the tumor type, age of diagnosis, and then the mutations that we're seeing. And this is really obvious to us as genetic counselors, but I think that this alone gives us a lot of information, particularly age of diagnosis. So for me, I see both adults and kids. When I'm looking at a breast cancer sample, for example, and someone who's 35, I say, stop. Why are we reviewing this? This patient needs to be seen by genetics. There are standard of care guidelines out there that say any woman under age 45 with breast cancer needs to be seen by genetics. As much as this report is going to be interesting to us, I'm not interested in doing double work and seeing extra patients or discrediting patients who should be seen anyway. And so one of the first things I tell all my doctors is that if a patient meets NCCN guidelines that are already established care, regardless of what their tumor profiling results are, they need to be seen by genetics. And I do this, one, because the tumor profiling is not a germline test, right? So it is possible for tumor profiling to miss mutations that are in fact in the germline. There's a few reasons that can happen, but it's also possible to have the opposite. It's possible to have mutations picked up that the doctor thinks, okay, well, this patient had a BRCA1 mutation, they're 35, they had breast cancer, this must be germline. You know, there's been other breast cancer mutations or breast cancer cases in the family, and therefore ignoring the PALB2 mutation that was actually deleterious that was just in the VUS section of the report. So I do recommend all family members, and this just makes sense to us, that meet NCCN or ACMG practice guidelines, regardless of what their tumor profiling results are, see genetic counseling. It doesn't mean that I don't look at those mutations, and I often am using that, particularly in cases where patients don't meet insurance criteria. I'll often use tumor profiling reports to help get germline testing done, but I don't want to be missing any cases. The second step, and this is something that I'm always working with doctors on because I think it's one where as genetic counselors we have a lot of tools that physicians are not well versed in, is looking and actually filtering those mutations. So telling the difference between a mutation on the report that is deleterious versus a variant of uncertain significance is something that doctors are not well equipped to do. And so there's a few things that I'm always looking for. So is a mutation actually deleterious if we looked at it on the germline side? Is the mutation that we're seeing a hypermutated result? So are there more mutations than we should see in that given sample type? And then any type of founder mutation. And I can't emphasize enough how often we see founder mutations that are just missed by doctors. So check to 1100 LC. I see a lot, regardless of the tumor type, any patient that has a founder mutation in a germline gene should have germline testing to confirm whether or not that is truly there. And then I put these patients into two different bins, high-risk patients and low-risk patients. For my high-risk patients, I always say refer for genetic counseling. And then for my low-risk patients, I again remind my doctors that they need to be reviewing all family history and that there are still important other components to genetic counseling referrals that exist. So I wanted to talk about allele frequency a little bit before we go into the cases today, and that's because it's a hot topic in the field whether or not variant allele frequency will be used in the future, particularly in cases like the ones I review where only the tumor is being sent to help determine whether or not germline testing should be done. And I like to point out that allele frequency here differs from our traditional model. We're not talking about population genetics. Here we're talking really about allele-specific copy number. So the percentage of that particular mutation is in your sample, regardless of other mutations in the sample. So here we often don't see an easy 50 or 100% allele frequency. We're often seeing ranges. Is it a 45% allele frequency, 75%? Part of the problem with using variant allele frequency to predict germline potential, and this is something I talk on a lot, is that these particular samples are not germline, and so these tumors throughout the tumorigenesis process gain and develop these mutations at different times. And really when laboratory looks at tumors, you can use variant allele frequency to almost create a timeline of how the tumor came about by seeing mutations which have a higher allele frequency are more likely to have been earlier on in the tumorigenesis process versus later ones that you see in the subclones. But there's also a number of other reasons why tumor variant allele frequency for any particular variant might not be 50%, even if it's a germline mutation. So for example, let's take that 1100del-C germline mutation in CHEK2. Well, we know that CHEK2 has a pseudogene. And so actually I'm not familiar with whether or not 1100del-C is in the pseudogene region, so that may not be a good example, but let's take a mutation that is in that pseudogene region of CHEK2. Well, that allele frequency is not going to be 50% by most accounts. It's going to be closer to 25% if that was in fact a germline mutation that the patient has. So this can be very confusing, particularly to clinicians. And so this is one of the reasons why a lot of laboratories do not necessarily report on all the test reports, the allele frequency. There's also other problems like tumor heterogeneity. When during that tumorigenesis process did the mutation occur? Driver mutations, which commonly occur earlier on, are often have higher variant allele frequencies, making them, potentially look germline even if they're not. And then things like copy number variation. So if you have large deletion events in this tumor going on, it's going to throw off the technology that is being used. That's often CGH array analysis that is being used to determine and calculate copy number variation or allele frequency. So I just have some case examples that I wanted to go over. The first is an 11-year-old male with a diagnosis of acute lymphoblastic leukemia. This is a young guy that I saw in clinic. There was no significant reported family history, so I asked the clinicians when we review these about the family history, but particularly in the pediatric side, I find that a lot of the family histories that we get are not very detailed. They're often asking just about first and second degree relatives, people who are so young, particularly in the case of young kids, that if there is a hereditary predisposition syndrome in the family, we don't see it necessarily on the pedigree unless you take a more extended pedigree. So when we looked at the result for this individual, the doctor noted that there was a TP53 mutation and sent the patient to come see us. I requested more information, so when we get these foundation results or Caris results, whichever ones we're looking at, many of the laboratories are not giving us the coding information for these. They're giving us the protein nomenclature. And this is a real problem for genetic counselors who evaluate and see these results, because really we know that for many of these, if we don't know the specific coding mutation, then when you're going into ClinVar or into our databases, you don't really have the true mutation, so you don't know which mutation you should be looking at. So you often need to request the coding nomenclature for these samples. In this case, we did, so it was a C.1096T to G. And when we looked at the mutational allele frequency here, it was at 50%. So here we have a kid with ALL who has a 50% allele frequency of a TP53 mutation. We looked up this mutation in ClinVar, and lo and behold, this was a mutation that is considered uncertain significance or even likely benign. So this particular case example happens to me all the time to us here at Children's and on the adult side. Discordance between what the germline laboratories will call a particular mutation and what it's being called on a foundation report. So these genomic alterations that are listed here are presumed pathogenic by foundation, but here on the germline side, when we look at this particular mutation, it's even potentially likely benign. And so this is one of the first things that I do every time I'm reviewing one of these results, is I try and get a clearer picture of whether or not we would be concerned about this result if we tested this on the germline side. And I'm sure you guys are all thinking, what if I had seen this kid and had done this testing and gotten an uncertain significant result? This is what I like to prevent ahead of time. We don't really want to be testing families for variants of uncertain significance if there's not a clear indication that testing should be done for another reason besides the tumor profiling result. So this happens all the time, and it's one of the most important things that I discuss with our clinicians is that variant classifications can differ between resulting laboratories. We know that this was a problem in the germline world, but it really is a very significant problem between the somatic and the germline world. The somatic laboratories do not have the large internal databases that our germline laboratories do, and they often, it appears, are not using germline databases to help make variant classification calls. And so we actually find that this is a very significant problem. It is not uncommon for me to see mutations listed on the first page of a report that are presumed pathogenic that actually end up being a variant of uncertain significance or benign, and vice versa. We also see a number of variants of uncertain significance listed on reports that end up being, if they were seen in the germline, considered pathogenic. And the amount of literature that exists on some of these mutations can be quite staggering sometimes. There was, in fact, a case at MD Anderson of a patient that had a founder mutation in MSH2. It was one of the Ashkenazi Jewish MSH2 mutations that was listed in the VUS section of a report. And so when we're reviewing these, I do very carefully review both the pathogenic section, but also the VUS section of these reports, because we do find that that's a very significant problem. In this case, we didn't recommend any germline testing for this case. There was no significant family history when I went into the history with the family, and no germline testing was done. Now, in this case, I actually met with this family in person to go over and discuss all this, but in retrospect, probably in these cases, I would not see this family in the first place in cancer genetics, just due to time constraints now. So talking about TP53 mutations in general, I think on the pediatric side is difficult. And please chime in if you have any questions at this part, because I think that this is a very controversial topic about whether or not when we look at these foundation reports, we should be testing for all the TP53 mutations that we would be considering pathogenic on the germline side. This is a debate that my group had recently, whether or not every single case that we see that has a TP53 result should be followed up on. The problem here is that TP53 mutations are very common. So the average amount of TP53 mutations that we're seeing in some tumor types can be up to 30% of that type of tumor that we see TP53 mutations in. And that places a significant burden on the medical field to follow up on these results, particularly if this testing is being done commonly. When we look at some of the data, so I know many people are familiar with the data out of St. Jude on the germline mutations in pediatric cancer. And when we looked at what we were seeing in those samples, they did find that a very significant proportion of the pediatric cancer cases that had germline predisposition syndromes did have them in TP53. Now, when we really break that down, what they found in their overall cohort was about 19% of the pediatric cancer cases had TP53 mutations in their tumor profiling results. When you filtered for that, and you filter that out, about 4% overall of the cases had germline TP53. So it went from 19 to 4% when you filtered out what was not germline. But still, 4% is a huge percentage of pediatric cancer patients with TP53 mutations, a very significant syndrome. Of course, that particular cohort had a very large number of ACTs. And so when you account for those, it was about 2% overall that had germline TP53 mutations. But what was really interesting within that data set was the number of tumors that we don't see. So there were 3 individuals with wing sarcomas, a number of leukemias, And really this suggested to us and my group that we really do need to be assessing those TP53 results that we see on pediatric cases for germline predisposition. And so we've taken the stance that we are going to be assessing all the TP53 mutations seen on tumor profiling reports, and we are going to offer those families germline TP53 testing, even in the case of Ewing sarcoma. That's the stance my group has taken. We know that the data, particularly regarding whether or not you do follow-up in these families and what follow-up you do based on the Toronto-based studies, is emerging. We think that the data itself right now lends itself to support that we should be screening, but there were a number of problems with some of the more recent studies showing that we should be doing screening and how often that screening be done. And I think that's still a conversation a lot of the pediatric centers need to have. The second case, I guess I can take questions if anyone has questions about TP53 or what we do at our institution. Otherwise, I'll talk about the second case.
Go ahead if you guys would like to, if you have any questions, you can either type it into the question box or raise your hand. All right, let's see. I did have one pop up, so let's see. All right, so question is, when you do follow-up testing, do you do site-specific or full TP53 sequencing?
Oh, great question. So this is a question I get all the time on the tumor profiling results. Do we do site-specific or do we do full sequencing? When I'm concerned that there is a mutation, so if any patient meets criteria for testing, I always do full sequencing. If the only reason for doing testing was that I was concerned about a variant on a tumor profiling report, I do site-specific testing. However, when I do site-specific testing, I always send in a copy of the tumor profiling report to the laboratory just to make sure that the laboratories are on the same page as far as what they should be looking at. But particularly when we start talking about BRCA, for example, I have a number of families where we have a BRCA mutation on the report, but the family meets for BRCA1 or 2 testing. I always do full gene sequencing.
Okay, that's helpful. The other comments as related to that were just, I'm wondering about coverage on the tumor testing, and I guess it would depend on the indication and family history. So it sounds like you addressed that. And then just clarifying, someone says, your team is offering TP53 germline testing to anyone with a TP53 mutation in their tumor profile. Is this after you've checked ClinVar?
Yes. So we offer it to anyone with TP53 mutation in their profile after we've checked ClinVar. And part of my process is that we've demanded that in order for the genetic counselors at our institution to review these results, the people who order the testing have to get the CDOT nomenclature. And that's really made it possible for us to both review these results, but also do so in a way that is logistically possible. I simply can't spend the time requesting the CDOT nomenclature from the laboratories myself. It's an intensive process. Oftentimes they won't release it to me, they'll only release it to the ordering clinician. So in order for us to review the results, we ask that they get that, and then we'll review it for them. If it's uncertain, we recommend no testing at the time, and if it's considered likely pathogenic or pathogenic, we recommend the family be seen for germline testing.
Okay, thank you.
And then to follow up on insurance coverage for testing, I've actually found that insurance coverage has been relatively good. So I wrote a paragraph about how molecular tumor profiling can be concerning for germline results, but that testing for this is based on expert review, kind of my own LMN a while back that I used for each of these cases. And we really haven't had problems with insurance coverage. Of course, many of my patients are Medicaid, so they don't get balance billed, but we haven't had large problems with insurance coverage for these cases.
And I just had one, oh, sorry, Brian.
Yeah, no, go.
You had one more question, and then I had one too. So I'll ask mine real quick. With the founder mutation that you mentioned, I think it was an MSH2. Is that what you had
Yes.
said? I was just curious, like, if anybody else would have handled that differently, just being that it's a founder mutation, and you would expect, I guess, a family history since Lynch is rarely de novo, although I will say that we've had one early colorectal cancer that was early onset presentation, but she did not have a founder mutation. So anyway, if anybody has other comments on that, I'm just curious. In the meantime, I will read the other questions. In the adult onset genes like BRCA1 and 2 and Lynch in minors, if they're found on somatic testing, I don't know. Oh, I'm sorry. Do you do germline testing for mutations in adult onset genes like BRCA2 and Lynch in minors if they're found on somatic? That was the question.
So this has been a debate in our group, and we do approach these case by case, but I will tell you that we often do. So one of the biggest debates is particularly the BRCA genes. BRCA1 and BRCA2 are big pains because we know that these are important, particularly for the patient's parents if this is germline and they have a low de novo incidence. And then particularly when we see these mutations on somatic reports, there's actually a quite high, and then this is anecdotal from my own personal experience, but it seems like there's a quite high chance, particularly for the BRCA mutations, to actually be germline. And there's a few reasons why that might be. One of the reasons is that those mutations are not driver mutations, and they tend to not be de novo, even in our germline families. But we've actually seen nearly 60 to 70% of the BRCA mutations we see on these tumor profiling results when we do follow-up confirmatory testing are germline. And so we do have a really high concern for those particular genes. How we approach it on the children's side here is that we have a conversation with the parents. So we discuss just all the implications that go into testing children for germline predisposition genes. We specifically address that if they're positive, we will not test their siblings until they're adults, and that doing testing now is really for the benefit of the parents and for the family. This has been controversial with our doctors. Some of them are on board. Some of them actually very much insist that we offer this testing, and others are not so on board with this. I think one of the options that we've considered in the past is just potentially testing parents for the mutation and not testing the child, but that seems like it defeats the purpose. If you find that particular mutation in the parent, there really isn't a lot of question that mutation is in the child. And then a lot of our conversation centers around life insurance and implications, but many of our clinicians also feel like many of these cases are not going to be eligible for significant life insurance coverage in the future. So it's something that's debated. There's no simple answer, but yes, we do often offer testing for those families, and mostly it's for the purpose of providing appropriate care for relatives rather than the patients themselves.
Okay, great. Thank you. Go ahead and continue on.
Yeah. So this was a case that I saw of a 21-year-old female with a diagnosis of Ewing sarcoma. The family history was completely non-contributory. There was actually a family history of breast cancer, if I can recall, and one of the maternal aunts. They actually met criteria separately for BRCA1 and 2 testing, but was not related to the report that we were reviewing. What we found on her report was that she had the AWSR1 fusion, and that she also had a TP53 mutation. When we looked at the mutation, we saw that this particular mutation had in ClinVar been considered likely pathogenic, and the mutation allele frequency was 45%. So this was one of the first cases that I really saw and reviewed, and it really stuck with me because the clinician insisted that because the mutation allele frequency was at 45%, this must be germline, and therefore, it'd be irresponsible not to offer this testing. It must be there. And so we did, in fact, test the family. We discussed that Ewing sarcoma is not generally considered to be associated with Lee-Fraumeni syndrome. It would be very difficult to provide a family if she did come back with a Lee-Fraumeni, a germline mutation that is consistently Lee-Fraumeni syndrome. It becomes very difficult to know how to follow this family. Here's a girl who has Ewing sarcoma. The family history was not consistent with Lee-Fraumeni syndrome, despite the fact that they met BRCA1 or 2 criteria. There was more due to like breast cancer in the 60s, I think. And so it becomes difficult to know what to do on follow-up. We did germline testing for her. She was negative for the TP53 mutation, but then we got this wonderful little comment from Ambry showing that they had found the particular mutation in her blood, but it was at an amount detected in trace, and that was not confirmed on Sanger. And so, of course, this, and what they're really saying is there was, we found this, but in such a low fraction that we don't think it's germline, which is a problem when we're testing patients that have active disease for this. We know that this low frequency TP53 mutations has been a really big concern for the labs, and what do you do when there's 10% of the sample? It turned out that she had more like 2 in 10,000 reads that were showing the TP53 mutation, so we were really not concerned that this was germline. But it's becoming a problem to know whether or not, what if it was 20% of her reads that had showed this particular mutation. So in this case, we were relatively reassured that this was not a germline mutation. But again, just emphasizing that variant allele frequency is not always indicative of a germline mutation, particularly when we see these driver mutations, TP53, APC, CDH1. These can be very, very commonly in the 50s to even 100% range on variant allele frequency or a mutant allele frequency, and are often not germline. Again, we still follow up on ours, so I don't use variant allele frequency to determine when we should do testing or not. I think that there's a lot of research that needs to be done. What I think that we'll find in the future is that driver mutations like these will probably not be informative based on the variant allele frequency, but non-driver mutations, things like BRCA1 or 2, I think what we'll find is that those will actually have a significant correlation with the variant allele frequency and whether or not it's likely to be germline. So if I simplify that, I think that in the future, if you see a BRCA mutation at a 50% allele frequency, you should be very concerned that it's germline, whereas if you see a TP53 mutation, I think that it could most definitely go either way. So the third case is something that has started to come up, and I think is one of the most interesting things that we can see on these tumor profiling results, because this is really a case that impacts us as pediatric cancer counselors, and that is the hypermutated tumors. So patients where the number of mutations within their tumor itself is very high compared to what is standard for that tumor type. So this was an 8-year-old with a newly diagnosed high-grade glioma. The family history had breast cancer and then a grandfather with stomach cancer. They were both in the 50s or 60s. Really nothing striking to us. When we looked at the sequencing results, however, there was a very high tumor mutation burden. And if I remember correctly, the report for this patient was 99 pages long. It was very significant. What we're looking at down here is this additional finding. So this is something that Foundation does now that they didn't used to do, but now they actually calculate the tumor mutation burden relative to other tumors of that particular type. And so what we're seeing is that there were 98 mutations per megabase, and this is considered high for high-grade glioma. When we look at tumor mutation burden, it is very specific to tumor type. So this is from a Nature paper which reviewed tumor burdens per tumor type. And what you can see here is the standards for things like melanoma, which has a very high overall tumor burden, is quite a lot higher than, for example, Allele. And then the red line indicates our patient, which had 89 mutations per megabase. So it was, again, quite high, even compared to like the low-grade gliomas and the glioblastomas. When we looked at that initial report, you'll see on here that there were no genes implicated with hypermutation or mismatch repair deficiency, but when we looked at the VUS report, all of a sudden we see that there's a lot going on. And so there were 3 MMR gene mutations, several POL-E mutations, a POL-D1 mutation, and then interestingly the tumor itself was MS stable, but again, this is a high-grade glioma, and so we don't know really how that acts in MMR deficiency. So what this result should really tell us is that this child needs to be evaluated for CMMRD or a Lynch syndrome mutation. Again, I think that this is a challenging case for us as pediatric counselors. People with Lynch syndrome will also have hypermutated polyps, but we need to be following, hypermutated phenotypes, but we need to be following up on all of these hypermutated cases, determine if they might actually have CMMRD. And so for these individuals, I will often run a Lynch panel with the POL-E and POL-D1 genes. And I do strongly feel that every case of hypermutated tumors should be followed up upon. With most of these results that we're reviewing now, if the patient does not have a hypermutated tumor, it'll actually be listed in the VUS section now. So they do actually list if the patient does not have a hypermutated tumor now. That was not something that was previously done, I think, before September of 2016, and is something that is being done now on these reports. So this case, we actually don't have the results yet because I just reviewed this case and the family hasn't been seen, but we do know that Foundation recommended that this child be referred to Toronto to be part of their CMMRD study, which really strongly suggests that they do think that there is a mismatch repair or CMMRD deficiency in this child. One of the things about Foundation testing is that oftentimes they're receiving a lot of normal sample with their tumor sample, so even though they're only reporting that they have tumor sample, they actually see in their analysis a lot of normal tissue. And so sometimes you can get hints from their reports that something a little bit more is going on, which I think we see in the case of them recommending that the patient be seen by a group for BMMRD. We actually have a case like this that we do have the results on, and the patient did in fact have an MMR gene deficiency. That was an adult, so that adult had Lynch syndrome, not CMMRD. But certainly this phenotype is very dramatic and something that we can easily catch on tumor profiling, where the family history is not necessarily striking for this syndrome. Okay, so this is my last case, and this is an 18-year-old male with a diagnosis of B-cell acute lymphoblastic leukemia. He's a patient that I saw recently, and he actually had cerebral palsy. He was born at 25 weeks. Prematurely and has significant cognitive delay. His sister was not born prematurely. She has significant cognitive delay. And then his brother had a reported tumor removed from his leg. His dad had an eye tumor removed. The family history was quite interesting because he's taken care of by a caretaker who's a distant relative, I think like a third cousin twice removed. So had a good idea of what was going on with the family, but just no specifics. When we looked at his tumor profiling result, what we found was that there was a BRCA1 mutation and then a RUNX1 mutation here that we were concerned about. And so one of the new challenges that I have, because something I'm not familiar with are the hematologic malignancies, is knowing when to test patients for these particular gene mutations. So we know that, again, he has Allele. He has a RUNX1 mutation. We know that within RUNX1 mutations, if you go down and look in the Foundation report, you can see that about 7.1% of all TLL samples have run X1 mutations. This, again, is not talking about germline versus somatic. It's just talking about somatic, but we do know that a significant number of them have these mutations, and the real question is what percentage of them are germline, and we don't yet know that answer. So this is a list, and if you haven't listened to Sarah Bannon's talk on hematologic malignancies or Jane Cherpick's talk, both those talks are available on the NSGC website, and they do a really, really great job of breaking down when you should be evaluating patients for these syndromes. Sarah Bannon actually recommends, and something that they do at MD Anderson is they follow up on all patients that have mutations in CBP alpha. Remember, when we're looking at leukemia samples, the test that we just did, regardless of me calling it a tumor-only test, is essentially an ipso facto germline test because we were looking at the patient's blood. The problem with that, of course, is that that's also the malignancy in this particular case, and so we often need to follow up these samples by doing skin biopsies and fibroblast culturing, which is a significantly more intense process than just seeing a patient in your office for germline serum testing. So something that they do at MD Anderson that is not something that we do is they actually follow up all the mutations that have mutations that are consistent with their cancer type. I think that they have the ability to do there. It's a large center that has a process for this. Here we're a little bit more conservative in the families that we see, and that what we often do, we look to see if there's 2 mutations. So if on the report you see a 5' RUNX1 mutation and then you see a deletion or a 3' mutation, we're often concerned about those samples having a germline mutation due to the nature that these are often biallelic mutations that actually cause the phenotype. So we look for those on our reports. The other thing that we do is I do take a more thorough family history in these cases. So I'll often do testing if there's a single mutation, or recommend testing if there's a single mutation and a family history of that disease. We don't quite have the means here to follow up on every single patient that has a single, just a combination of the disease and that mutation. But I think that we look forward to there being in the future, hopefully, recommendations for when this testing should be done. So mutations in these genes are actually quite common when we look at overall hematologic malignancies. These particular genes are often involved in the tumorigenesis pathway, so it's very common for these to be present. And that's part of the reason why I don't test everyone that just has a single mutation in one of those genes. And then again, the reason that we're not is that it's a more involved process, the skin biopsy, the fibroblast culturing. If we did, it would pose a significant burden on our clinic right now. And I really hope that there are recommendations in the future. Again, I think all genetic counselors should watch Sarah Bannon's talk. It's really, really excellent. Jane Cherpick also did a talk, and this has really helped me know when we see these hematologic malignancies, what we should be doing. So some take-home points that I have, just some of the things that I've learned myself, is that all mutations on these reports and their VUSs should be reviewed. It was really tempting in the beginning because there's so many VUSs on these reports for me just to look at the mutations on the top, but I learned very quickly that you're going to miss some true mutations by ignoring the VUSs. The family that I have that has the hypermutated Lynch syndrome case, the mutation itself was in the VUS section of the report and was not in the pathogenic section of the report. When possible, obtain CDOT and allele frequency information if you can't get the doctor who referred to give you this information. These laboratories all do have forms that you can have the family sign, and you can request this information yourself. I call customer service or I email them a lot of times. That's the easiest thing. All patients who meet genetic counseling criteria, either through ACMG or NCCN, should be evaluated regardless of these results. I can't emphasize this enough. I tell the doctors we work with all the time, if the patient meets criteria for genetic counseling, independent of these results, they need to be seen, and they need to have the most appropriate testing for them. Even if the patient has a BRCA1 mutation, if they meet criteria for BRCA testing as an adult here at my center, we run a full breast panel, regardless of what their testing results are. And that's because this type of testing can miss mutations. Again, there's a lot going on within these tumors themselves, a lot of deletion events, and this is not a substitute for germline testing. And then my final take-home point is that allele frequency should be used cautiously. I think this is going to be in the future a very valuable tool, particularly when we're looking at tumor-only testing. But I think that right now, caution should be used. I think places that make guidelines, oh, we're not going to test it if it's less than 10%, should be really cautious, because of course a mutation is going to be less than 10% if there's something drastic going on. Think about all the breakage syndromes that we test kids for and the amount that's going on in the genome there. So I am happy to take questions about our experience here, or would love to hear feedback from anyone who does things differently, because I think this is a really exciting area for genetic counseling.
Thank you so much, Ryan. That was a great presentation. I do have a couple more questions that had come in during your final part. So one was, how are patients referred for genetic counseling from the testing providers? I know some institutes have all the tumor results reviewed by their GCs, but we have been told by our legal department that due to HIPAA, we cannot, and specifically would need the patient's consent for their provider to discuss the result with our department. Is referral solely at the provider's discretion?
So I think that's interesting, and you might want to talk to your HIPAA department. We review these cases in Tumor Board, and we have organizational permission to do so. So whether or not their providers come, their providers have given permission for us to review all of these cases for them. And a molecular tumor board, we could do that outside of molecular tumor board. I could simply get the provider's permission to review these cases for them. There's a lot of leeway when it comes to HIPAA when you're talking about the betterment of care for patients. So here, we're not reviewing these cases for research purposes. We're quite literally reviewing these to help know if we can change the care for families. So something to ask about. These molecular tumor boards are very common. There's a lot of ways that they go about, but it's something to consider. The way the referrals are done for us is that after we review these cases in the molecular tumor board, we send emails to the doctors if they weren't there regarding what our recommendations were in the molecular tumor board, and then they place referrals in EPIC to our group.
Thank you very much. And then another question was, how reassured would you be for Li-Fraumeni syndrome risk in a patient with an osteosarcoma with no TP53 mutations? I.e., do you ever use the data as a point of reassurance when counseling?
No, I would never use the data as a a point of reassurance to a family, sure. A point to not do testing, absolutely not. So would I tell a family who meets criteria for Li-Fraumeni syndrome anyway that they need to do the germline testing if they truly want reassurance? Absolutely. Would I use a test like this to say, hey, this was negative, that's probably a good sign that your germline testing should be negative? Sure. But would I ever use this in lieu of doing that testing? No, I would not. And again, one of those reasons is if you have a large deletion event and your original germline mutation was within that event, it's not going to show up on this report. And the way that this testing is done, it's quite possible for that to happen. So we see all the time allele frequencies are at 100% or at like 2%. And when you think about tumors and what must be going on to provide allele frequency like that, what we know is that there's a lot of major deletion and duplication events that are happening within these samples that make it quite possible to miss germline mutations. And so while I think that anecdotally you can be reassuring and say, you know, this means that there's probably a good chance that there's nothing there. I would always follow up if you're concerned about something in the first place, a patient that meets criteria, with doing germline testing.
Great, thank you so much. Okay, well, it looks like we are almost at time. Does anybody have any final thoughts or want to share anything or comments? Just make sure I'm checking everything. Okay, I don't see anything else popping up, so I just wanted to let everyone know that this will be archived. Oh wait, sorry. We do have one more comment, but this will be archived, so the recording will go up on our YouTube channel most likely. So if you have any colleagues that did miss this, please reassure them that I will be posting that, and then I will send out a link to our subcommittee. The final comment was another comment. Our pathologists have missed mutations before. So that's, I guess, just an FYI. So yes, definitely. Okay, well, thank you so much again, Brian, and thank you guys all for attending. I hope you guys have a great rest of the day.
Thanks, guys.
Thank you.